ஸ்லைட் ஷோ பண்ணாங்க நீ அமீன் தெரியுமா? ஸ்லைட் ஷோ பண்ணாங்க தெரியுமா? நான் தெரியாது. அவன் சொன்னாதானே மாற்றுவான். சரி அவங்க இது ஒர்க் ஆகும் தான் ஒர்க் ஆகும் பார்த்துக்கலாம். அந்த டைமில் நமக்கு ஒர்க் ஆகுது. ஓகே.
We kindly request everyone to take their seats so that we can start with the scientific sessions.
சார் வேறு ஒன்று ஓப்பன் பண்ணாமல் இருக்கு ரெண்டு.
அது இங்கே இருக்கு ஸ்பீக்கர். செல்வம்
Of enriching scientific sessions at MedAIR 2025. For the first session, it is my pleasure to introduce our moderator, Dr. K. Karthikeyan Sir, Dean Academic, Professor and Head of Dermatology at SMVMCH, known for his keen eye for academic excellence in sculpting young minds. So we kindly request you to introduce our speaker and moderate the session on use of virtual reality in medical education. Please, sir.
Hello.
Good morning. Good morning. I think it's my privilege and pleasure to introduce one of the doyens in medical education, Dr. Avinash Supe. Sir needs not much introduction. Being a BC Roy awardee and his publications more than 342 papers and 625 presentations, and also honored with Doctor of Science Award. I don't think Sir needs much introduction, and I think we will be very enriched by his talk on integrating AI, innovations and research in medical education. Over to you, sir.
Thank you. Can I have my presentation? Sure. The topic which I am going to speak is today on virtual reality in medical education. I would like to thank the team of MedAIR, Dr. Kange Sir, Uday, Saundarya, Amol and everyone. Now I'm sure virtual reality is something which is, you're creating an artificial environment experience through sensory stimuli. And all of us have enjoyed many times games into the Imagica and Disneyland and all. These are nothing but virtual reality games. So there are VR sets which are emerged and immersive games. Many of us have played these games before we really go. And when we talk about education and digital surgery, I think virtual reality has come in practically all parts of education, like designing, post-operative, intraoperative. Now I remember way back in '97 when laparoscopic came, we used to have this laparoscopic training through a small VR, and that time it was called as a very low immersive VR. And then came VR adopters. You know, surgery is amongst the most influential adopters. If you really look at VR, surgery was almost 7.7% all over the world. If you really look out of the healthcare, surgery was one which was taken care by the VR. If you look at publications of VR and surgery, look at the kind of publications which have come. Virtual reality and surgery, they have increased over last few years, and large number of publications, almost about 2,000 around publications every year. Now what is most important in VR is the degree of immersion. How much of immersion we are going to be? Are we going to be a low immersive or high immersive? How much you are getting engaged into the whole thing? So let's begin with a very simple thing about illusions. There are types of illusions, you know. That means ultimately VR gives you an illusion, and it could be a place illusion, it could be plausibility, or it could be an avatar-based embodied illusion. Many of you must have been to, say, Empire State in USA, where you go and they show you that you are descending through Empire State and you are seeing the whole New York. That is called as a place illusion. And it's a feeling of being in a virtual environment. Plausibility is when they give you a scenario, you are working in a casualty, you are working somewhere else, and then you are really trying to treat a patient. That is called as a plausibility evaluation. And third is what is called as an avatar-based embodied illusion. That means you create avatars of different people and then you are working with them. So actually either it's a place, plausibility, or avatar-based illusion with which you really work. The second most important is some of the virtual reality is a non-immersion reality, otherwise it's a semi-immersive or an immersive. What do you really mean by that? The degree of immersion may change, depending upon non-immersive to immersive. I'll give you a few examples. Non-immersive means you could have something like this, where we used to do a laparoscopic surgery or a touch surgery. We used to use this, and with that we used to make people really work. Semi-immersive is like this. This is like you are changing complete laparoscopic surgery, and you are now trying to put a clip, you are trying to do an ultrasound, and then you are trying to put a hand and palpate. This is something like that, what we call as a semi-immersive kind of an environment, where we would like to really look at the liver and do a laparoscopic surgery, put clips, and these are all today available for our students to really learn. But this is something what we call is like, say somebody wants to learn gastric banding. So he can really learn on this gastric banding, and then he can put a clip. So then, the experience he gets is much more. Students also get a feedback, what he has done well, what he has not done well. So the next thing is something like laparoscopic. The lap mentor came somewhere in about 2000. And it started teaching people how to do laparoscopic surgery. So you can hold the gallbladder, you can pull it, it bleeds also occasionally, and then you started cutting, and this is called as a lap mentor immersive systems. You could do something like this, you can have an distension of the gallbladder, abdomen, you can pass a trocar, and then you can see inside, you can take a cautery and you can start cutting liver. Now these are all illusions, but they are immersive illusions. You would like to really enter and do a procedure, and then you can really do a hepatectomy, which is very well with this. This is one GSL lab, this is Rajmandri. They have really developed this immersive lab. Now look at this lab. You can walk into this lab 360 degrees. You can lift the kind of a heart, you can rotate it, you can touch every valve, and you can really see this. Now the students enjoy this much more. Of course it should be part of your learning, not completely replace your learning. Now VR always has a visual content. It was actively participating and reacting on the visual content. 360 degrees, something like that. But now what has happened, previously there used to be a flat screen. So now we have started getting VR heads. We used to get these headsets. Now this was a kind of a thing which I learned laparoscopic surgery in 1900 and something like 95. And we used to have making people learn. This is the way we used to use to how to progress the intestine, and this was a VR, this was called as a mist VR, it was a flat screen virtual reality. But now we have what is called as a cave, that is called as an automatic virtual environment. I think if you really see some of these panoramas, Swiss panorama or world panoramas, where you can walk through and 360 degrees rotates with us. So same thing happens in a OT, when you're working in a OT, it would create, so it creates a haptic, tactile and vestibular kind of a response, which was not there before. So to give you VR visual feedback, you could have so many desktop plays, phone based or something like that. But now we have started getting tactile and haptic. Look at this virtual reality for vestibular rehabilitation. People who undergo cochlear implantation, they need to be trained for vestibular rehabilitation. This is all done through their VR sets, and this is something which is amazing. Then our hospital has got program called Mind Maze. Now this program is for people who are recovering from a stroke. Now what they do, you sitting like this, and they are playing games. Actually elderly people are playing games. And with playing games, they get a particular kind of exercise. Also they give a feedback. So the virtual reality helps them to rehabilitate themselves through various kinds of exercises, mentally as well as physically. This is a haptic kind of a neurorehabilitation. VRs are used in operating room, like pre-planning, operative guidance, and post-operative complications. To give you an example, we have to understand the word called mixed reality. Mixed reality is one hand we have virtual reality, other hand you have augmented reality, and the third is a mixed reality. So real environment on one side and virtual environment on the other side, and we have augmented reality and augmented virtuality. And there's a term called extended reality, where you mix with low immersion or a high immersion. Now once you understand, there's a continuum actually, from no device to the VR, we are going from real environment to the virtual environment. So you can have anything which is mixed. To give you an example, this is a created image of liver if I want to do a hepatectomy. Now I can hold this liver, I can rotate it, I can see where are the vessels coming. So this helps me to operate these patients and do it better. To give you an example, and is it useful? All performance of newly devised systems are comparable to the traditional techniques, and people are now started routinely using this in their operation theaters. In fact, there is something called as a HoloLens 2, which is now, again, there are a lot of new things coming up, where you can use large 3D images for learning. Like, look at this liver, again, we have created this for our patient, and now I can hold it and I can really see the anatomy, and I can make a liver of this whole auditorium size, and I can rotate it with the virtual reality. So the kind of ease and training which really comes with this is amazing. We can do 3D printing, you know what is called as a holographic navigation. You can create a bile duct by the side of you while operating with the VR, and something like, and this is intraoperative image guidance. I can do a partial hepatectomy, keep it by the side of the patient while I'm operating. I use a VR head and I can really know and see what kind of a resection I'm doing. Now see, I can pinch it and I can keep it wherever I want, and this is the way I can make my operations more precise and doing. And this is all being done. It's not something which I'm talking from heart. We have tried this all and we have been doing many of these. Then iSim VR, you know, I bought for the mobile robot stimulator. VR perimetries are done with the virtual reality. Many times when you do a visual perimetry, there are some lacunae. So virtual perimetries are done better. VR operating room planners. You can really create an operating planner so that this is all like CRM, crisis resource management, teamwork, all these are now played with the help of VR. Post-operative reflections, VR can advance your reflection by helping healthcare professionals to relieve situations they have encountered. You can have a debriefing, you can make people learn in that way better. So if you really look, put it into a paradigm, you have a, can we go back? Sure. Anyway, can we just go back? Just help me. I think it is not coming there. Sure. So if you go to this paradigm, you have a high fidelity versus low fidelity. I'm sure all these medical educationists understand what is fidelity. Accessible versus costly. If you really see, cadavers are high fidelity, costly, not very easily available today. AR, VR are costly, but they are low fidelity. Physical models are high fidelity, accessible, but sometimes there's an ethical issue. And desktop models which are low fidelity and accessible. So we have to really understand which one which you want to use based on what is available to you. Now, what are the educational examples? We can use it for teaching medical anatomy. Many of the colleges today have anatomage. Familiarization with surgical workflows, developing technical skills, managing crisis scenarios, experiencing rare procedures, realistic decision making in a virtual hospital, and definitely having situational and spatial awareness. Now this is something which is very important when people are working in teams. I think yesterday in the gamification, the Raj was talking about this situational awareness. Now this is exactly is very well learned through virtual reality and team training. Now look at this kind of an anatomage. These are there in many labs where you can really, instead of cadavers, now it is being partly replaced by this anatomage where students can build on muscles, they can build on anything. I mean, you can bring muscles, you can bring vessels, and you can start working on these kind of anatomage.
The ureter is closest to the pink zone. The rectum is closest to the red zone. So our green zone in the midline is the one with the greatest safety zone with both the ureter and rectum at safe distances.
Well done. In what direction would you place the suture? Speak the color of the correct arrow.
When we're placing sutures, our area of maximal control is the entry point. So we're going to put our entry point from lateral to medial, as that's going to be closest to the ureter.
So what is this girl trying to do? She is trying to learn how to prevent ureteric injury while doing the
One of the
colectomy.
3 sutures.
So
Which one is the most
it gives a
practical?
feedback to her also that you have done well
The one
done.
very close
She is
to the
trying to
ureter,
do it
and that's
VR,
the
she is
one
trying to
to
say
the
where to
ureter.
put a stitch. Now this kind of a level of training is much different, and the level of competence they get before they enter the operation theatre. Now see, many of our students, we learned it by operating on patients. So there is always chance of getting mistakes. There is always a history of patient injury. But if you learn it like a higher level, then probably the chances you cause injuries are less. You have to learn on patients, I'm not saying, but you can prepare yourself better before going on that. And there are enough amount of publications today which say that augmented reality in surgical training, there are systematic reviews, there are so many publications in transplantation which would help you to say that this has proved to be effective. And if you see use of 3D, mixed reality, augmented reality, whether it has helped into this, there are enough publications which would say that this has been of a great help.
Meanwhile,
Like another thing which people do is the 3D printing. Now what do they in 3D printing?
On the left.
This was I saw in Korea.
On the right.
There was a patient being operated for thymectomy,
Tumors are removed.
and they created complete 3D replica of the patient where the students were observing their boss and they were operating, and they're doing exactly the same procedure that they were doing for that thymectomy. Now, I think this is a different level of training. You can't really replicate it everywhere. Now, AI has come. AI and machine learning will analyze these investigations, and it will predict difficulty. It will guide your port placements today, layering of tissues and dissection, steps of surgery. Like this is a mixed reality. You know, this is where gynecology, many times, you know, today women are very ethically you can't really ask somebody to do, students to do it. So look at
The
this.
group is going to be understanding the same reality. So
Can
now
you
the
increase the
instructor
voice?
can really focus on how to manage a complication. Nothing ever has provided that level of information. It's not a textbook, it's not a video, it's not a PowerPoint presentation that's going to give you that kind of understanding. CA Healthcare selected shoulder dystocia as the first scenario on Lucina AR because it's a rare complication of delivery, but it's one that's difficult to manage. You have a number of options, you need to think fast. Seeing the anatomy, seeing the progression of the baby in the birthing canal, and seeing where the shoulder gets stuck is going to be very helpful to understand how to fix it. Seeing them in front of your very eyes as a student is like a revelation, right? This is the future of healthcare education. Really beyond the spectacular of that experience, there's an educational purpose that we're fulfilling, and that
So this is where you can teach your students about complications of delivery and reduce the risk of getting complications. What are the limitations of VR? We need more data to prove its clinical utility and improve patient outcomes. You know, it improves the level of training, but does it improve the patient outcomes? We really don't know. We still have to work on this. Cost is a major issue. Efficiency and effectiveness of VR training simulators. We need to create people who know all this. Cyber sickness. This is another thing which many students have said, that we are all the time working with IT. You know, I think this is something which all we have to get through this. This is a future direction of HoloLens based surgery. You know what, we put on HoloLens and we do HoloLens based surgery. And I can be in the remote. Now recently I think people conducted semi based surgery. That you are in Switzerland, you are conducting a surgery in USA or in Singapore. This is called as an HoloLens based surgery. Right? To be very frank, I use this technique not for surgery but for teaching in remote countries like say Nepal and Bhutan where there is a good internet. And I realized that as an experiment we did it and it was very, very useful that you could really train surgeons about what they are really doing. You can do this captive view microscope for brain surgery, real-time imaging to reduce intraoperative disruptions. VR in nursing education is very well accepted. You know, people have been using it for doing VR. Now, because of the cost, there was an issue, but today I think there are now Indian startups which are coming. This is a company in Chennai, which is hardly 4 hours from your place, which is virtual reality in healthcare, medicine VR, and they are now doing with IIT Chennai, and they have created multiple VRs which are very cheap. They are not very costly as we normally would like to buy. So I feel in next few years, we'll be able to get access to this kind of an VR where we'll be able to get much easier education to our students. Apple Pro, Vision Pro has been coming. It has come in USA, not in India, costly. But I'm sure in the next few years, we are not going to have a MacBook Pro. We will have only an Apple Pro Vision and we will all do the kind of filing and Word through our all Pro Vision. So to summarize, virtual reality is emerging as an educational strategy, as a surgical support tool. Of course, not only in surgery, but also in the many other procedural skills, medicine, ophthalmology, orthopedics, mainly surgical tool, because it has more predominance with the skills. Recent advances in software and hardware have reduced consumer cost and allowed better use for immersion. It is better available today than on an experimental stage. VR is now both accessible and affordable, increase adoption in future. I think as the time will go, more and more people will adopt it. What we really need to do is, VR is currently in its early days, need to determine acceptable risk of real world scenarios to create opportunities. What we really need to do is a proper integration of VR and mixed reality in our curriculums. Now partly it has come. You know, we are experimenting, but partly places people are doing this. And I think this is most important, where we try to take segments of our curriculum where we can use VR or mixed reality as part of their curriculum. This means coexistence of virtual world with the real world. I think thank you so much, and if there are any questions, I'm sure I'll take them.
Any questions from the audience? There are no questions. Thank you, sir, for the enlightening lecture. Thank you, sir. Question.
Thank you so much, sir. You have shown a lot of articles related to this VR and all. Only one question. Is there any article that published with the limitations and how far it is very close to the a student trained with VR, and while doing a real surgery, what are the difficulties?
See, most of the articles say that it is equivalent in teaching the level of competence you reach. We still don't have articles which say that the patient outcomes have improved because of virtual reality. Now the second point is, if I have trained myself, will I really directly go and operate? No. If you really look at pilots training, they work on VR first, then do few thousand of hours as a co-pilot with somebody, and then they become the ordinary pilot. The same principles follow. Maybe the level of competence which you are entering into the actually real world is better. I'm not saying it replaces your real world training, but currently it will improve your level, and initially, you know, the kind of damages is to caused by if you're directly doing procedure, this definitely reduces those damages to the patient. Okay? Sure. Yes, you have any question? Please.
You were talking about the 3D printing, sir. How far is it useful? Because it can be used only once, if I am right.
Yeah, it is. See, there are now in India, there are many places 3D printing is used for, especially for neurosurgery, spine surgery, liver surgery, and dental surgery. You know, I don't know, you've seen a 3D printing. I think I have seen 2-3 3D printing labs in India, and where students really work, they print their tooth. It's only for a patient based. You are learning about one patient. So it costs about 15,000 to 20,000 for a liver. Maybe for dental it costs about 2,000 rupees because it's a small 3D printing. Neurosurgery it costs about 20-25,000. But people are ready to pay for that. That's what I'm saying. It's coming to, like in KM hospital, our neurosurgery and liver surgery people use it. If an odd case, especially a vascular case, they use it. It costs. It's only for one use. It's not, 3D printing is only for one case.
Just on the lighter note, quacks now they read about drugs and then start prescribing. Like this, I mean, now they use VR and then they start operating also.
Not necessarily. Will you get operated by them? That's a question you should really ask yourself. I think it's a question of training little better, that's all I feel. So.
Hello sir, I totally agree with you because we have this medicine VR and I've been working with students and I found that retention of knowledge is better when they use some VR. But definitely we will not allow them to go ahead and start practicing.
You should publish. If you have an experience, you should publish because let people others know that there's a better detail.
It has been published sir, already.
Sure, great.
So, and one thing sir, which we notice in the images sometimes it's very artificial. It doesn't reflect the actual image in anatomical images. So there's a problem with that. So how, so any
See, this is ultimately, I feel this is a technology in development. And I think if you see the previous kinds of VR and today's VR, there's a vast difference. In next 4-5 years, I think we will be quite real-like.
Thank you, sir.
Thank you for your doubts.
Sure.
Any other things, sir, will be there to answer it during the lunch. Thank you.
Thank you for that enriching session, sir. Now I kindly request our moderator, Dr. K. Karthikeyan, sir, to felicitate our speaker, Dr. Avinash Supe, sir. Please, sir. Thank you, sir. I kindly request Dr. M. Shanti, ma'am, Professor and Head Department of Pharmacology, to felicitate our moderator, Dr. K. Karthikeyan, sir. Please, ma'am.
Thank you, ma'am. Thank you, sir. For our next session on balancing AI tools with essential research competencies, a critical balance that needs attention, we are privileged to have as our moderator Dr. G. Shivaraman, sir, Additional Professor and Head of ENT at JIPMER, whose commitment to academics and meticulous approach inspires learners across all levels. Sir, we warmly